Tiny. It's a pleasure for me to introduce Dr. Shoamanesh. He is a good friend from Hamilton, and he is actually an assistant professor in the Department of Medicine and Neurology at McMaster University. He's the director of Hemorrhagic Stroke Research Program and investigator of the Stroke and Cognition Program at the PHRI, also there in Hamilton, Ontario. He's the inaugural Marta and Owen Boris Chair in Stroke Research and Care at McMaster University, and is the director of the Stroke Fellowship Program also at the Hamilton Health Sciences at McMaster University. He is the founding director of the Hemorrhagic Stroke Research Program within the Stroke and Cognition Program at PHRI. He did his training at the University of British Columbia, followed by some more training at Boston University, and then at Harvard University. He came to McMaster, I guess it was sometime around 2014, where he holds the Marta and Owen Boris Chair in Stroke Research. He's been very active since he came to PHRI at McMaster, and his main research focus is characterization of hemorrhage-prone cerebral small vessel disease and the optimization of clinical care in patient population. He's part of the Navigate ESIS, IntoStroke, Compass Mind, and Invictus Trials teams, and he's a co-principal investigator of the Nasdaf Ich trial, which is a phase 2 multicentral randomized clinical trial investigating optimal antithrombotic therapy in patients with high-risk atrial fibrillation. He's also the Canadian National Investigator for the Saturn randomized trial, and he is also a co-principal investigator and chair of the Canadian Hemorrhagic Stroke Trials Initiative, Cohesive. So he's a very active young man and one of the rising stars in this area, and it's a great pleasure for me to introduce him. He's also had several manuscripts published, over 80, I guess, in the last few years. And he received a Young Investigator Award at the Stroke Conference in 2014, American Stroke Association, Mordecai YT Globus New Investigator Award, and several other awards. And he's going to give us a little tour about antithrombotic therapy in patients prone to bleeding in the brain with a lot of the diseases that we usually handle. Ashkan, pleasure to have you here with us today.
Well, thanks so much for the very kind introduction, Carlos, and for the opportunity to present to you this morning. I had provided a very brief bio, but it seems you pulled up my online bio, so thank you for going through all that. I'll be talking to you today about a topic that's actually been an interest of mine since really I got interested in clinical research during my residency, and that's the risk-benefit analysis of antithrombotic therapy in patients who are prone to bleeding in the brain or have hemorrhage-prone cerebral small vessel disease with comorbid cardio and cerebrovascular disease. I do have a number of relevant disclosures. The most kind of pertaining to our talk would be that I have worked in various capacities, both in a research and advisory capacity with the companies that produce direct-acting oral anticoagulants, which they'll discuss today, and Daiichi Sankyo, which makes Edoxaban, has funded a large phase 3 global trial that is now has taken where Nasdaf Ich left it off, the discussion about anticoagulation post-ICH in patients with AF, that I'll also discuss. So our objectives to one, define hemorrhage-prone cerebral small vessel disease, discuss the clinical dilemma of antithrombotic therapy in this vulnerable disease population. And we're going to split the population into two different ones, because one is people who you only find these occult MRI markers of prior bleeding who have never suffered a prior hemorrhagic stroke. And of course, their risk-benefit analysis is going to be quite different than those who have actually already had a prior symptomatic intracerebral hemorrhage event. And then we're going to summarize recent relevant randomized controlled trials, as well as some of the future directions in this area. So the two, I think, most common and relevant cerebral small vessel diseases that contribute to bleeding in the brain are the age-related ones, which are cerebral amyloid angiopathy and hypertensive arteriopathy. And then just for some of the trainees, don't confuse cerebral amyloid angiopathy with systemic amyloidosis. This is a completely different disease that is confined to the brain, where a similar protein that causes Alzheimer's disease becomes soluble, gets into the perivascular space, and for reasons we don't quite understand, starts depositing in the vessel wall, replacing smooth muscle cells, making the blood vessels vulnerable to vessel rupture. And the topographic distribution of CAA is really one where your patients get lobar bleeding, either microhemorrhages that are found incidentally on MRI, as depicted in this MRI towards the left, or large macrohemorrhages that are symptomatic and cause hemorrhagic stroke. The additional one, which is actually much more common, is hypertensive arteriopathy or arteriolosclerosis, where you have namely deep microhemorrhages and deep macrohemorrhages, but also if it gets severe enough, you can have lobar. So hypertensive arteriopathy will cause both deep and lobar, whereas cerebral amyloid angiopathy is confined to lobar bleeds and rarely cerebellar bleeds. And these conditions are actually quite common. In pathological studies was suggested, for instance, CAA is present up to a quarter of patients over the age of 80 that reach autopsy. And within the Framingham Heart Study, when you just look at kind of community dwelling older populations who are in the community, who undergo random MRIs, you'll find that 21% of them have ischemic manifestations of these small vessel diseases, such as white matter hyperintensity, or these that you'll hear reported on MRIs as chronic microvascular changes. 13% will have covert infarcts, such as these subcortical small strokes. And then 70 to 100% will have this newer marker that's being recognized of cerebral small vessel disease, and that's dilated perivascular spaces. And then when you look at the hemorrhagic manifestations of some of these diseases, you'll find that 20% of those in the community will have cerebral microbleeds detected on MRI, and this could be either in a deep or mixed pattern as depicted here, suggestive of hypertensive arteriopathy, or a strictly lobar pattern as depicted here, suggestive of amyloid angiopathy. Cortical superficial siderosis is present in about 0.45% of the community dwelling adults. This is much rarer, but a much more potent marker for underlying cerebral amyloid angiopathy in the absence of prior head trauma. And then you about another similar 0.35% have actually had prior occult or symptomatic macrohemorrhages detected on imaging. Now, why is it that some people with the same underlying cerebral small vessel diseases go on to develop these markers, whereas others don't, is still uncertain. And there may be some interactions with genetic profiles, namely in the ApoE epsilon allele for CAA. There's also hypertensive risk score alleles or genetic scores that may contribute to it. It may be the individual's kind of inherent marker profile and inflammatory cytokines that are circulating them, and there's some data such as that. But also, of course, there's the clinical risk factors that then can aggravate these underlying small vessel diseases. And this is data by Marta and O'Donnell, which was performed out of the PHRI, the interstroke case control study, where amongst 3,059 first ever ICH and roughly 10,000 controls from 32 countries, they identified that 7 risk factors attributed or accounted for rather for 87% of the population attributable risk of having asymptomatic hemorrhage. And your biggest, of course, contributor was a history of hypertension, which accounted for 56% of the population attributable risk, followed by lack of regular physical activity, unhealthy diet, psychosocial stress, elevated waist to hip ratio, current alcohol intake, and current smoking. So just take a minute to look at these modifiable risk factors that you see here, because if you do have a patient that you are going to be starting an antithrombotic and they do have underlying hemorrhage-prone small vessel disease, you really want to make sure you're tackling all these risk factors to minimize their risk of bleeding moving forward. And as the cerebral small vessel diseases that contribute to bleeding are age-related, and as are the kind of atherothrombotic and thromboembolic diseases that necessitate antithrombotic therapy, having the comorbidity of these diseases together is going to increase in our aging demographics. So diseases such as coronary artery disease, AFib, ischemic stroke, and ICH are going to be seen more and more frequently in coming decades, not only individually, but their co-occurrence in the same individual is also going to increase. So this question and clinical dilemma is not going away. And already when you look at pooled data from the Framingham Heart and Rotterdam studies, you'll find that amongst patients with strictly deep microbleeds, 10% have a history of ischemic stroke, 57% are on antithrombotic therapy already, and 41% are on statin therapy, which may increase the risk of hemorrhagic stroke. That's still an ongoing debate, but there is suggestion of perhaps a twofold increased risk of hemorrhagic stroke with statin therapy. Strictly in patients with strictly lower microbleeds, similar distribution, about 5%, 43%, and 34% respectively. And for siderosis as well, about 5%, 42%, and 45% respectively. And this is concerning because these MRI markers, of course, not only indicate the underlying pathology, but are also predictors of future vascular events and future stroke. So for deep mixed microbleeds, increase the risk of future ischemic stroke or TIA, in ischemic stroke or TIA cohorts, rather, so in people who have not had a prior ICH. Deep microbleeds will increase their risk of having a future ICH threefold, but it also increases the risk of ischemic stroke twofold because it is an underlying marker of vascular risk factors, age, frailty, etc. So I think we need to focus on both these risks when we're thinking about treatment decisions. Strictly lower microbleeds, a much more potent risk factor for a hemorrhagic stroke, a tenfold increased risk versus a twofold increased risk of ischemic stroke. And we're still understanding more and more about superficial siderosis, but it seems to be a very potent marker of ICH. Whether or not it has the same risk of future ischemic stroke is uncertain, but the data is quite preliminary currently. Now, you could imagine the stroke literature over the initial decades that actually looked at these lesions was looking at these relative risks and saying, holy crap, look how high the risk of bleeding is in these individuals. And we should really avoid antithrombotic therapy or be concerned and cautious when we're going to use antithrombotic therapy in these patients. But of course, these are relative risks and not absolute risks. And I think that's where a lot of confusion arose in microbleed literature, because when you look at absolute event rates and someone who has never had a prior intracranial hemorrhage, so we're looking at an ischemic stroke population here, and this is a large individual level meta-analysis, which probably provides the most robust evidence on this question, you'll find that the baseline risk of symptomatic intracranial hemorrhage in patients without any microbleeds is about 0.4% annually, or 4 per thousand. But the risk of having an ischemic stroke is 3% annually. So if you're going to double this versus a tenfold increase in this, you're actually still going to end up with greater absolute event rates of ischemic events. And I'll show that here. So for instance, for people who have extremely high microbleed counts, so 20 or more microbleeds on their MRI, that rate of future symptomatic intracranial hemorrhage does increase about 9-fold. But that then translates from 0.4% per year to 4% per year. However, the ischemic stroke rate in that same individual has gone from 3% to 7.5% per year. So it still outweighs the hemorrhagic risk. If you look at kind of patterns suggestive of amyloid angiopathy, you're going up to a 0.9% risk per year versus a 5% risk of ischemic strokes. And realizing that the absolute event rates of ischemic events outweigh hemorrhagic events has started to change the conversation about this dilemma. So what about some randomized controlled trials? So the very first trial I got involved in that kind of created my interest in this topic was the SPS3 trial, which was an NIH-funded trial led by Oscar Benavente, looking at optimal antithrombotic therapy as well as blood pressure control in patients with lacunar stroke who do have the same underlying pathology as deep hemorrhages, or that being hypertensive arteriopathy. And overall, it was a 2x2 factorial design trial where patients were assigned to either receive dual antiplatelet therapy with aspirin Plavix versus aspirin monotherapy, or strict blood pressure control to less than 130 versus usual blood pressure of 130 to 149. And the antiplatelet trial was stopped early due to increased mortality in the dual antiplatelet therapy group over 3 years of treatment, whereas the blood pressure arm of the study suggested a 20% relative risk reduction in recurrent stroke with a more intensive blood pressure target of less than 130 systolic, but it's not reached statistical significance with p-value of 0.08. However, a predefined secondary outcome of intracerebral hemorrhage, there was about a 60 to 70% risk reduction that was statistically significant. And I'll just mention, because I won't show the data, that in patients with microbleeds, this benefit was amplified. So patients with microbleeds and lacunar stroke seem to benefit even more, and there was a treatment interaction to suggest they benefited more from this intensive blood pressure target. So of these trial participants, 42% had images available to assess microbleeds, 30% had at least one microbleed, and over a mean follow-up of 3.5 years, the rate of recurrent stroke was 2.5% per patient year of follow-up. There was about 100 total events. 83 were ischemic, 16 were hemorrhagic, so we weren't able to look at hemorrhagic strokes in isolation, and one was of uncertain etiology. And overall, having a microbleed, any member of microbleeds versus no microbleeds increased your risk of stroke during follow-up by about two-fold. And not only were patients at increased risk of all recurrent stroke, but if we were to screen out those with intracerebral hemorrhage and just looked at ischemic events, the adjusted hazard ratio did not meaningfully change. It remained around 2.3. The incident ICH occurred in 1% of patients with the no microbleed group and 1.3% of those in the microbleed group. And when we looked at for treatment interactions for the outcome of recurrent stroke, according to whether patients were assigned to dual antiplatelet therapy or monotherapy, there was absolutely no suggestion of a treatment interaction with baseline microbleed presence, nor was there one with microbleed number or distribution that we looked at separately. And this was also true for looking for the outcome of death. So we did not find any suggestion of a treatment interaction with microbleeds and different potency of antithrombotic therapy with antiplatelet agents in this study. Then there was 3 MRI sub-studies and PHRI-led trials. The first was the Averroes MRI sub-study in patients with AF who were assigned to Efficacy versus aspirin. The Compass Mind sub-study of the Compass trial, which we all know well, which randomized patients with systemic atherosclerotic disease to receive either rivaroxaban 5 milligrams twice daily, rivaroxaban 2.5 milligrams with aspirin. Or aspirin monotherapy, and the Navigate ESAS Mind MRI sub-study, which looked at patients with embolic stroke of undetermined source who were randomized to Riva 15 versus aspirin. And all these studies, the MRI sub-study had MRIs at baseline prior to randomization, and then an end study MRI to look at the accrual of not only covert infarcts, but also hemorrhagic lesions. And this there was no increased risk of microbleeding with any of these agents relative to aspirin. So when you look at the Averroes MRI sub-study, microbleed prevalence was 35% in this AF population who underwent MRI. And the number of patients who had developed new microbleeds was 7% in study on Efficacy versus 7% on aspirin. Similar results were seen in Navigate ESAS. Now, Navigate ESAS was stopped prematurely due to excess bleeding with Riva 15 versus aspirin that was not offset by any clinically meaningful benefit reduction in stroke in patients with embolic stroke of undetermined source. But this was a global trial, really over 400 sites in over 30 countries, kind of all across the globe. And in these patients, we also looked at treatment interactions according to baseline MRI profiles. And 51% of the 7,000 participants who participated in Navigate ESAS had microbleeds reported on their baseline MRI and were included in these analyses. The median age of the population was 67, and 37% were women. 11% had at least one microbleed, and over a mean follow-up of 11 months, recurrent stroke rate was 5%. And that's but really, when you look at the outcome of intracerebral hemorrhage, there was no difference in terms of response to treatment to rivaroxaban versus aspirin, whether someone had microbleeds or not. I'll mention that in the entire trial, rivaroxaban did increase the risk of ICH relative to aspirin threefold, but that threefold increase was the same in patients with or without microbleeds. There was absolutely no treatment interaction, p-value 0.97. And it didn't matter whether you looked at microbleed severity or distribution. There was really no treatment interaction suggesting excess risk of bleeding with Riva versus aspirin in patients who had microbleeds. Now, of course, patients with baseline microbleeds did have a higher event rate even on aspirin. So a threefold increase does translate to a larger absolute increased risk of hemorrhage, right? So from 0.5% to 1.6%, so an absolute 1.1% risk increase, and versus in patients who didn't have microbleeds, it went from 0.1% to 0.4%, so a 0.3%. So there is actually an increased absolute excess risk, but not a proportional increased risk and no treatment interaction as such. And I'll go in the next 2 slides from now, I'll mention how this may be translatable to AF Of course, we can't do any risk-benefit analysis in ESUS because there was no benefit with anticoagulant therapy. But if these results were to translate to AF populations, which isn't unreasonable because the baseline underlying small vessel diseases that contribute to microbleeds in ESUS are likely very much the same as those that contribute to microbleeds in AF. But as far as our DIS analysis, we were able to kind of confirm that randomization to rivaroxaban compared to aspirin did not increase cerebral microbleed accrual, that there was greater rates of recurrent stroke, ischemic stroke, and ICH in AVIC-EDSIS participants with microbleeds. And in the first trial assessing interactions between microbleeds and the effects of randomized anticoagulant therapy on clinical outcomes, treatment with rivaroxaban was not compared with a high relative risk for ICH in persons with microbleeds compared to those without. And that these results may be generalizable to other ischemic stroke subtypes. And this is kind of where they may be generalizable to AF. So there's a number of assumptions and estimates in this slide, but just try to follow me. So this is what we observed in our analysis, and that in patients who were assigned to Riva 15 daily versus aspirin, in patients who had 1 or 2 microbleeds, their excess risk, absolute risk of ICH was 1% per year. In those with 3 or more microbleeds, it was 1% per year as well. And in those with strictly lower microbleeds, it was increased to 2% per year. Now, assuming that there's a 50% risk reduction with ischemic stroke with Riva 15, which is very similar to Riva 20, versus aspirin in AF patients, someone would require at least a 2% risk of ischemic stroke with thromboembolism to benefit from or have net benefit from anticoagulation versus aspirin. And if they had 1 or 2 microbleeds, 2% if they had 3 or more microbleeds, and 4% if they had strictly lower microbleeds. And then that would translate to somewhere between a CHADS of 1 or a CHADS of 2. And as all ischemic stroke TIA patients with AF would have at least a CHADS of 2, just based on the basis of having had an ischemic stroke or TIA, they would have net benefit irrespective of microbleed status, and we really should stop worrying about it. Now, these event rates are also likely very conservative because there is evidence to show that microbleeds does increase someone's risk of having future ischemic strokes in AF patients at a level that is independent of CHADS risk factors. So patients with microbleeds likely have even higher rates of ischemic events than those depicted here at these CHADS levels. So, so that is quite reassuring. And then we did a subsequent publication kind of estimating the absolute risk reduction with anticoagulation and excess risk of bleeding. And if anything, there was perhaps our estimates would suggest that there was even greater net benefit from anticoagulation in patients with microbleeds who have AF, who have not had prior ICH. We're only talking about those with baseline ischemic stroke or TIA, because they just have a much greater absolute event rates of ischemic stroke versus ICH. So to conclude the microbleed portion of this talk, forget about microbleeds when you're looking at antithrombotic decision-making, unless someone has already suffered an ICH, where there is their importance becomes a bit more elusive, and we're trying to figure that out. And the only thing that microbleeds does for me clinically is that it triggers me to target a blood pressure of less than 130, whether I'm going to use an antithrombotic agent or not. And it triggers me to also ensure that I'm not using excessive antithrombotic therapy. For instance, if someone doesn't need an antiplatelet agent, and there's no good evidence to support an antiplatelet agent on top of an anticoagulant, then I wouldn't pursue it, or I would discontinue that agent. And also, I'll screen these patients for cognitive impairment, but that's a different topic altogether. So let's move on to ICH patients. So now we're moving to patients who have already suffered an intracerebral hemorrhage, whose baseline rate of having a recurrent ICH is roughly somewhere between 2% per year in those with hypertensive arteriopathy to 7% per year in those with lobar ICH deemed to be secondary cerebral amyloid angiopathy. So you could contrast that relative to like the 0.4% or 0.3% per year in patients who just have an ischemic stroke, right? So here, if you have excess risk due to microbleeds, it may be more clinically relevant, but we still haven't figured that out. But the comorbidity of these vascular competing thromboembolic and vaso-occlusive diseases is also quite present in an ICH population. And this is just our ICH cohort at Hamilton Health Sciences, where 20% of our ICH patients have AFib, 17% have coronary disease or MI, 10% have ischemic stroke, 9% have suffered a TIA, a quarter are on antithrombotic therapy, a third are on statin therapy, and really these patients tend to be undertreated because when looking at their indications for antithrombotic therapy, 43% had an indication for secondary prevention. And our prevalence is about the same when looking at AF and ICH patients, and then in Western populations, roughly 16% will have of incident ICH patients will have prevalent AF. Now, this becomes much more challenging because whether or not to reinitiate anticoagulation in someone who's already suffered an ICH becomes a challenging dilemma where you have to kind of weigh the robust known benefits of reducing these thromboembolic events and it's devastating ischemic strokes versus the risk of increasing that person's risk of bleeding or having another bleed, and also perhaps larger bleeds if they were to occur on blood thinners. Now, moving over from AF for a second, the very first kind of randomized trial in this area was the RESTART trial, and RESTART randomized patients who had an ICH and had any indication for antithrombotic therapy. So that could have been coronary disease, peripheral vascular disease, prior ischemic stroke, or AF, as long as the investigator was okay with it for them to be randomized to either antiplatelet therapy or nothing at all. Antiplatelet therapy could have been either aspirin, clopidogrel, or dipyridamol, or any derivation thereof. And interestingly, when they randomized about 500 individuals, so this is not a phase 3 kind of fully powered trial, what they found was that in resuming antiplatelet therapy versus avoiding antithrombotic therapy altogether, there was actually a suggestion of a reduced risk of recurrent ICH during follow-up with a 49% risk reduction. But of course, the confidence interval does cross the null with a p-value of 0.06. And I think it still is hard for us to accept that antithrombotic therapy is actually reducing the risk of ICH. I think there's ways you can speculate why these may be true findings, independent of hemorrhagic infarction. They actually went back and looked at all the MRIs, and this is not due to just hemorrhagic infarcts being misclassified as ICHs, where, as far as the best of us can tell, true ICHs or primary ICHs. I think the way to best interpret this data, given the limitations in the small sample size and that it was an open label study, is that there is reassuring safety data that at most you're getting within this 95% confidence interval a 3% excess risk of bleeding with antiplatelet therapy versus nothing in someone who's already suffered an ICH, and that this marginal increase in potential bleeding will not outweigh the known benefits. And actually what they did show is replicated the known benefits of antiplatelet therapy for major vascular events in this population, and that antiplatelet therapy reduced the outcome of MACE by 35% relative to no antithrombotic therapy. So that robust benefit would not be outweighed by any potential increase in recurrent bleeding. And I think it is reasonable to restart antiplatelets in patients who've had an ICH who have a compelling indication for it. And again, when they looked at treatment interactions according to kind of whether it was a lobar bleed, so just of amyloid that has a higher risk of recurrent ICH, if they had this potent marker of future bleeding, superficial siderosis, if they had microbleeds, and irrespective of number or location, or if there was suggestion of underlying cerebral amyloid angiopathy on their imaging, the results were consistent across the board, and that there was no suggestion of excess bleeding with antiplatelet therapy. And our current Canadian kind of ICH guidelines published with the Heart and Stroke do currently state as a level B evidence that it is reasonable to resume antiplatelet therapy in patients with ICH based on these results, but of course is level B due to its limitations. And Rustam El-Shahi Salman from Edinburgh, who is the PI of this trial, is now trying to do the confirmatory phase 3 trial. So now moving on to AF, which accounts for or cardioembolic stroke accounts for about a quarter of all ischemic stroke subtypes, and AF is the most common cause of it. And the kind of clots that form in the left atrium, and namely in the left atrial appendage, tend to be large ones that block proximal cerebral small vessels that have the large territorial infarcts that result in the highest rate of death and long-term disability amongst all ischemic stroke subtypes. But fortunately, we have very effective medications at mitigating the risk of bleeding mitigating the risk rather of ischemic stroke in patients with AF, and that's anticoagulation with vitamin K antagonists or warfarin, which has historically provided a 64% risk reduction relative to placebo for the outcome of all stroke. If you look at ischemic stroke alone, that translates to a 67% risk reduction. So really robust benefit. And now in the age of direct-acting oral anticoagulants, there's an additional 20% risk reduction above and beyond the benefits of warfarin for stroke. And this is being driven namely by this halving of hemorrhagic stroke. Now, patients with prior ICH were excluded from all randomized controlled trials that looked at the benefit of anticoagulant therapy in patients with AF and the original closure trials, for that matter, for left atrial appendage closure. So we really don't have any direct evidence for this population, and we really didn't have even any good observational data until 2015, where a number of national registries were published from namely Europe. And this is a meta-analysis, an aggregate meta-analysis that was published in 2017 on all of the observational data. And when you compare resuming anticoagulation versus no anticoagulation for the outcome of ischemic stroke in patients with prior intracranial hemorrhage, the effect size is kind of replicating what you saw in the randomized controlled trials, about a 66% risk reduction relative to no anticoagulation for ischemic stroke, which is not unsurprising. But what is surprising when factoring that over 95% of this data is coming from reinitiation of anticoagulation with warfarin is that we're not seeing an excess risk of recurrent ICH when you pool the observational data. Now, again, this is interesting in view of looking at the restart results with aspirin or antiplatelet therapy that I discussed earlier. But we do know from the original AF trials that warfarin roughly doubles the risk of ICH, so it has become suspect. And of course, this is likely confounded, and that is my impression. This is confounded data and confounded by indication, in that physicians are choosing which patients are being resumed in anticoagulation and choosing which patients are not being resumed anticoagulation. So you likely have a higher risk population in a no anticoagulation arm, a more benign population in the anticoagulation group, and you're getting this artifact of safety that's really being confounded by physician treatment decisions. And this is why we really need randomized controlled trials to guide practice. But some of our survey data would suggest that the number one determinant of whether stroke neurologists would resume anticoagulation or not in a patient, or at least one where there's the most disagreement with a 1/3, 2/3 split, is if someone already has evidence of amyloid angiopathy, in particular if they have these aggressive MRI profiles. And this study was quite interesting in this regard because this was an individual level meta-analysis of 3 cohorts. One is the Retrace registry, which is a German multi-center registry, the MGH, Massachusetts General Hospital ICH registry, as well as the ERIC registry, which is a US multi-center ICH registry, in which they were able to actually identify patients who had lobar ICH versus deep ICH, and also look at if there was any kind of what were the effect sizes of resuming anticoagulation, again, over 90% with warfarin. And the benefits seemed very consistent in both lobar ICH and deep ICH patients. And then in the smaller sample of 190 individuals who they had MRIs to look at probable CAA, the resuming anticoagulation led to a 70% risk reduction in mortality at 1 year and a 3-fold increased likelihood of achieving a favorable outcome of on a modified Rankin scale of 0 to 3, which essentially means that the patient was either having no symptoms, symptoms with very minimal to moderate disability. Surprisingly, kind of in contrast to some of the conventional dogma in stroke literature over the past few decades, here you're showing that perhaps patients are getting mortality benefit and greater favorable outcomes with anticoagulation, again, with warfarin in this observational data set relative to no anticoagulation therapy. And it's really kind of turned the question on its head and has increased the need for randomized trials to guide practice. So the very first step we took towards this goal was the Nasdaf Ich Study, which was a phase 2 multi-center trial where 30 participants across kind of 10 sites in Canada were randomized to receive NOAC or aspirin monotherapy in a 2-to-1 fashion. If someone were to be randomized to NOAC, the physician had the discretion of whichever agent they preferred. However, they had to use standard dosing. They could not use off-label low dose. And all participants were followed to a common termination date defined as 6 months following the end of recruitment. And of course, Calgary was also one of the main contributors to this pilot study with Sheila Coots and Eric Smith leading the way. And I should mention that Eric has also been one of our biggest collaborators in many of the MRI sub-studies that I've discussed today. So we had 28 baseline MRIs that were actually rated at Eric's core lab. Although baseline demographics were evenly distributed between the two arms of the study, we did find that just because the small sample size of 30 individuals, we did not have even randomization of some of the MRI features, and that the NOAC arm was actually at a disadvantage in that they had much more aggressive MRI profiles. So 62% had 3 or more microbleeds relative to 22% in the aspirin arm. A quarter had more than 10 microbleeds relative to 11% in the aspirin arm. Almost a third had superficial siderosis versus none in the aspirin arm. And 62% had MRI profiles suggestive of amyloid angiopathy relative to none in the aspirin arm. And over a mean follow of 1.5 years that ranged between roughly 11 months to 3 years, depending on when the participant got into the trial due to a common termination date. And this translates to about 65 patient years of follow-up. We were able to get blood pressures down to our target of less than 130/80. And we did this by providing all participants with home blood pressure monitors and blood pressure diaries that were reviewed over telephone at least once every 3 months. And this is something I do in my clinical practice. I think it's essential for reducing the risk of recurrent ICH in all patients. And I think it may have influenced our results apart from the fact that we had a small sample size. Because when we looked at our primary outcome of ischemic stroke and ICH, we found that there was no events in the NOAC arm versus only 1 event in the aspirin arm. And that 1 event in the aspirin arm was actually an ischemic stroke that occurred in somebody who had their aspirin temporarily held after they suffered a GU bleed that subsequently led to a diagnosis of bladder cancer. And there was no recurrent ICH, fatal stroke, or MI in either arm of the study. All-cause mortality was 22% in the aspirin arm versus 5% in the NOAC arm. The composite of stroke, MI, systemic thromboembolism, or death was about 1/3 in the aspirin arm versus 5% in the NOAC arm. The MRS was slightly higher in the aspirin arm, suggesting greater disability at 2.5 versus 2. The MoCA suggesting lower numbers, suggesting more cognitive impairment, was slightly lower in the aspirin arm at 22 versus 25 in the NOAC arm. ISTH major bleeding was just the 1 GU bleed I mentioned earlier, and all hospitalization occurred in a 1/3 of the population, which just reflects the fragility and vulnerability of this population as a whole. There was no major difference between either arm of the study, 38% in the NOAC arm versus 33% in the aspirin arm. And then looking at the net benefit outcome of stroke, MI, cardiovascular death, fatal bleeding, and symptomatic bleeding into critical organ, it was 22% in the aspirin arm versus none in the NOAC arm. So really promising, very preliminary results to move on to a confirmatory main phase trial. We did establish the feasibility of a multi-center trial looking at this question and provide the first randomized, albeit very limited data on clinical outcomes according to different antithrombotic regimens in this population. And then this is where the Edoxaban for intracranial hemorrhage survivors with AF trial comes in. So this is a large global trial that we're leading out of PHRI, and my co-PIs in this study are Stuart Connolly, who many of you will know, as well as Bob Hart. So this is occurring at over 300 sites in 22 countries. We have had some delays due to the pandemic, but we're hoping to have our results ultimately presented in 2023. Here we're going to be randomizing patients 1-to-1, and these are patients that have high risk atrial fibrillation, defined as CHADS VASC of 2 or more, and prior intracranial hemorrhage to Edoxaban, 60 milligrams dose adjusted to 30 milligrams, so standard dosing Edoxaban, or non-anticoagulant medical therapy. Here, in contrast to Nasdaf, which was done just in Canada, we had to leave some wiggle room for what was considered kind of standard of care in patients who were not receiving anticoagulation, because in some countries, particularly in Europe, they don't use any antithrombotic therapy, whereas in North America and some additional countries, aspirin monotherapy would be the standard. All patients will be followed to common termination date, defined as once 123 primary events have accrued. which we estimate to occur 12 months following the end of recruitment in this event-driven trial. And our total study duration will probably be about 4 years due to the pandemic, with mean follow-up of at least 24 months per patient. Now, when we had the Nasdaf results, we actually weren't picky in approaching different industry sponsors or industry funders, rather. This is actually PHRI is the sponsor, but we have a grant and aid from Daiichi Sankyo to conduct a trial. But we were actually quite pleased that Daiichi Sankyo felt comfortable enough with their safety profile to kind of tackle this very high-risk population, an important clinical question, because as we know, as far as indirect comparisons go, and they are kind of filled with pitfalls, but is all we have in the absence of a head-to-head trial, Edoxaban does have the more favorable safety profile, or one of the more favorable safety profiles in this class, with major bleeding rates relative to warfarin that are on par with that what was seen with Efficacy. The median age of this population is 77, so this is a rather elderly population. And when, again, this is kind of post hoc analysis of these trials, but it has, for instance, influenced the label of dabigatran in Canada, in that both in RELY and in ROCKET AF, there was a suggestion of a treatment interaction with age, in that as patients got over the age of 75, they actually had excess bleeding relative to warfarin with the 150 milligram dose of dabigatran and with the standard dose of ROCKET or rivaroxaban used in ROCKET. And this is why, although in RELY it was a 1-to-1-to-1 randomization, the Canadian label says that in patients over the age of 85, you should consider the lower dose regimen. And if they're kind of over the age of 75, you have to really weigh their kind of risk of thromboembolism versus bleeding. Whereas in Efficacy and Edoxaban, there was actually no suggestion of any such age interaction, and that the major bleeding benefits was consistent across all age groups. Now, some have asked us, why did we go with the standard dosing and not the lower dosing of Edoxaban, the 30-15 milligram dosing regimen that was also tested in the ENGAGE-AF TIMI-48 trial? And the reason we didn't is for the same reason that I never go off-label low dose in my clinical practice. And that's because really anytime I start an anticoagulant or any blood thinner for that matter, I do expect an increased risk of bleeding with treatment relative to the alternative of a lesser antithrombotic therapy. But particularly in AF, I'm reassured by this massive safety net of this 67% risk reduction, these large devastating ischemic strokes, to offset any marginal increase in bleeding that may occur with treatment. That's why I never go off-label low dose in my clinical practice, and this is why we didn't go off-label low dose in this trial. And we were also reassured when we indirectly compared event rates of aspirin in the Averroes trial for hemorrhagic stroke intracranial hemorrhage, Efficacy in the Aristotle study, which was most similar to the ENGAGE-AF TIMI-48 trial, and Edoxaban in the ENGAGE-AF TIMI-48 trial, standard dosing of 60-30, and saw that the hemorrhagic stroke risk was 0.3% per year in Averroes on aspirin, 0.24% per year in Aristotle, and 0.26% per year on a standard dosing Edoxaban. Intracranial hemorrhage was also quite similar, with 0.4% per year, 0.33%, and 0.39% respectively across these different agents. And that's despite the ENGAGE-AF TIMI-48 trial actually having a higher risk population with a mean CHAD score of 2.8 relative to 2.1 in the other two trials. And as we know, the CHAD score is not only a risk factor for future thromboembolic events, but also future bleeding events, because some of the same risk factors for bleeding, such as older age, prior stroke, hypertension, etc., are also present, of course, in the CHADs and our risk bleeding scores. In addition, there's a lot of evidence, and this is just one study that's depicting this, showing that one of the biggest modifiable risk factors for having breakthrough infarcts on a NOAC in patients with AF is off-label low dose. And that in this study, the Reno trial, which was a case control study performed across 37 stroke units in Europe and North America, where 7 cases were defined as 700 patients with AF who had an ischemic event during follow-up, and controls were 700 patients with AF who were on NOAC. All these patients were on NOACs who did not have an event during follow-up. Off-label low dose led to a 3.2-fold increased list of ischemic stroke during follow-up, which was one of the most potent risk factors identified in this case control study. Now, some of the additional advantages of Edoxaban that I'll just highlight quickly are its superior efficacy for stroke prevention compared with warfarin. This was in the modified intention to treat analysis or on treatment analysis where patients were actually receiving drug. In the analysis or the intention to treat analysis, it was equivalent to warfarin for stroke prevention. Is the only drug other than Edoxaban that has provided mortality benefit relative to warfarin in patients with AF. The reductions in major bleeding we've discussed, and it's a once daily formulation whose bioavailability is independent of food. And as we know, for rivaroxaban, doses above 15 milligrams need to be taken with food to be appropriately absorbed. So that's something to make sure your patient is aware of. And this drug, like many of the others, can be crushed for administration through an NG or PEG tube or for pureed diet, which is relevant in patients who have dysphagia post-stroke. The only agent that can't be crushed is dabigatran due to its over-encapsulation with tartaric acid. That's important for its bioavailability. It has some of the least drug interactions in the class, which is important in an elderly population that we're testing in ENRICH-AF that has polypharmacy. In that, here you have, if someone is on a strong PGP inhibitor, the label allows for a dose adjustment as opposed to a complete contraindication, which is present in the other three agents. And similar to dabigatran, Edoxaban is the only other drug where there's no real concern or practical concern about CYP3A4 metabolism, which also leads to less concern about polypharmacy. And then there was a large number of patients tested at a lower dose, about 2,000 individuals who received the 63 milligram arm in ENGAGE FTME48 trial, and there's absolutely no suggestion of a treatment interaction. The p-value was as close as 1 as possible. So that's reassuring as well. And the one disadvantage, of course, is the increase in GI bleeding, which was also seen with Riva and Dabi relative to warfarin, but the overall mortality benefit and reductions in major bleeding account for that. Now, based on our kind of standard dosing regimen of the Edoxaban 60/30 versus non-anticoagulant medication, or non-anticoagulation medical therapy rather, which could be either antiplatelet monotherapy or no antithrombotic therapy, we estimate that our study will have a 80% power to detect a 40% risk reduction in their composite primary outcome of all stroke at a kind of alpha of two-sided alpha of 0.05. And these are the event rates that we're expecting, is that ischemic stroke will be roughly 6% per year in a no anticoagulation arm, relative and reduced to 2% per year in the Edoxaban arm. We have accounted for 1% absolute increase in hemorrhagic stroke with Edoxaban relative to no anticoagulant therapy to be conservative. We do not expect such a large increase, but we want to be conservative and account for the 66% increased risk. But despite that, we're still left with an overall 3% absolute risk reduction in our primary outcome of all stroke, which would translate, if accurate, to a number near treat of 33. I will just mention that after estimates, the EDNA-AF program was presented at the ESC in 2019, which is a real-world registry of Edoxaban in Europe. And in this registry, they actually were able to identify 325 individuals with history of intracranial hemorrhage, which are depicted in the dark blue bars relative to roughly 25,000 individuals who did not have a history of intracranial hemorrhage in the light blue bars. And a couple of things you'll notice is that similar to microbleeds, having a prior history of intracranial hemorrhage does not only increase your risk of hemorrhagic stroke from 0.28% to 0.8%, but also it increases your risk of ischemic stroke from 0.8% to 2.5% off on appropriate anticoagulation. If someone were to be off anticoagulation here, you can multiply that by 3 as an estimate, so about 7.5%, which is quite, I think, in keeping with what we expected with 6% versus 2% for our ischemic stroke event rate. And then for hemorrhagic stroke, again, I think we are being conservative in that here, they only noticed a 0.8% increase, 0.8% absolute risk of hemorrhagic stroke with Edoxaban. But of course, this is observational data. Again, it just may be that safer patients and patients who have lower risk for future bleeds are being included and treated with Edoxaban in the real world. And then for the intracranial hemorrhage outcome, which also includes subdurals, et cetera, again, not a major concern, about 1.2%, which is quite similar to what we expect in a natural history of this disease, even in the absence of antithrombotic therapy. So to conclude, the concomitants of hemorrhage-prone cerebral small vessel disease and vaso-occlusive thromboembolic disease necessitating antithrombotic therapy is due to increase with our aging demographics. MRI markers of hemorrhage-prone small vessel disease should not influence antithrombotic decision-making for secondary prevention in ischemic stroke TIA patients. Their clinical utility will likely be more relevant to anticoagulation in ICH populations, but this has yet to be confirmed, and there's ongoing trials, and we will do an MRI sub-study within the ENRICH-IF trial to be able to look at treatment interactions relative to baseline MRI phenotypes. And ENRICH-IF aims to clarify optimal stroke prevention in ICH survivors with AF, and Edoxaban seems well suited for this high-risk population, but much work remains to be done. I'll mention that ENRICH-AF is ongoing in Calgary. So if you do have any eligible patients, please feel free to reach out to our PI, Eric Smith, to enroll in this study. And hopefully we can answer this question together. And I'll end there for questions. Thank you.
Thanks, Ashkan. That's a great talk. There's some questions here. One of my questions was, so help me understand what's this interaction between microbleeds and ischemic cerebral hemorrhage with increased ischemic stroke. It's like, there still is a residual risk there that we haven't been able to tackle. So how do you get rid of that? What's going on there?
It's difficult to know entirely. On the one part of it is that microbleeds are largely, at least in most individuals, a manifestation of underlying hypertensive arteriopathy or arteriosclerosis of the brain. So not only can this contribute to ICH, but also lacunar ischemic strokes. So I think part of it is the small vessel ischemic strokes that are occurring due to the same underlying pathology. But there's an additional piece that we still haven't been able to fully understand, in that even if you look at non-lacunar strokes, ESIS, AF-related ischemic strokes, you do have a higher rate of ischemic events in patients with microbleeds, and this persists after adjusting for some of our known risk factors. Now, it may just be the limitations of kind of adjusting binary variables. For instance, hypertension, of course, is coded as 0-1, when really you know that the hypertension is a huge spectrum of patients with hypertension, and there's more that have more severe hypertension, they're not well managed, and those that are well managed, etc. So likely our kind of propensity match scoring adjustments and our regression analyses are not able to adjust for all that variability. Another piece of it could just be that these patients are older patients, they have more circulating inflammatory cytokines, and that has been shown. They're more frail and vulnerable, whatever that means as a holistic term, and that's likely driving their event rates as well. But it is an area of active kind of investigation.
Okay, some questions here that, when do you consider left atrial appendage occlusion in people that have had a intracerebral hemorrhage and have atrial fibrillation?
It's a good question. I think it's unknown right now because, as I mentioned, people with ICH were excluded from those trials. And if you look at some of the antithrombotic regimens that were used post-closure in the pivotal randomized trials, there were quite aggressive ones, right? They were getting warfarin and aspirin for kind of the first 6 weeks, and then dual antiplatelet therapy for up to 6 months, and then aspirin for life. If they didn't get full closure and there was a leak, then they got warfarin and aspirin for life. So that concerns me. Of course, we're now using more kind of benign antithrombotic regimens post-procedure, but we don't have any hard randomized trials to show that you're maintaining the benefit, and there are concerns about device thrombosis, etc. The evidence, I think, for left atrial appendage closure is quite low, and I think we would all agree that if it was a medication, it would never have reached labeling and regulatory approval. It reached approval because devices just have a much more streamlined and forgiving approval process. And I think based on all of that and the paucity of data, if you look at the current Canadian Cardiovascular Society guidelines, which I'm sure all of you have for AF, they're saying they're recommending left atrial appendage closure as a weak recommendation in patients who have an absolute contraindication to anticoagulation. Now, the kind of the main question, though, is what defines an absolute contraindication to anticoagulation, and that is quite subjective. But where in the guidelines, what they've suggested is that someone who's had 2 or more or recurrent ICHs or 2 or more bleeds in other compartments as well, and a few rare instances where just 1 bleed would indicate it. So that is in the guidelines, so you can take a look. I think that it's very reasonable to resume anticoagulation with NOAC in someone who's had their first ICH, if you're able to control their blood pressure and kind of go through falls prevention, etc. And that is what I do in my practice. I think I've only sent 1 person over the past 5 years to left atrial appendage closure. The vast majority of my patients are either getting restarted on NOACs with appropriate blood pressure monitoring, or even better yet, I think you should randomize these patients, right? I think they should be randomized into clinical trials, and you do have the Enrich-IF available to you. So just reach out to Eric Smith, get them randomized so that we can have actually some level A evidence to guide practice in the future.
Well, that happened after I left Hamilton, that you guys are not sending us any left atrial appendage. We could argue about that one, but we were doing some trials there that we were trying to conduct on that. Maybe those people that have amyloid or other of these MRI features that are associated with high bleeding, maybe I think those are the ones that I would probably send, and those are the ones we're doing here.
But the way I look at it is that in the end, these patients are going to be at least on aspirin, right? So it's not like you can avoid antithrombotic altogether. And as far as their incident ICH rates go, it's very reassuring that these NOACs have the same risk as aspirin monotherapy. We just have to prove that that applies to recurrent ICH after someone has already had an ICH. And if that does translate to a recurrent ICH population or someone who's already had a bleeding, then why would you go through the kind of perioperative risk, the risk that they may not get an appropriate seal and would need warfarin, or the risk of device thrombosis, when you could just put them on a NOAC from the get-go and likely end up with a similar safety profile as aspirin therapy, which they're going to be on post-device anyways. But again, this is all speculation, and we need firm randomized trials to guide practice.
Agree. So there's some more questions here about what are your thoughts about that new data regarding ultra low dose Edoxaban in elderly patients, the Japanese trial with 50 milligrams.
I'm not a huge fan of it. I think it's actually, the results will confuse practice and probably lead to underdosing more than I would like to see. And I'll mention it every time I'm on the stroke unit. I see at least 2 patients with AF who comes in with an ischemic stroke on NOAC at a lower dose. And if one thing to remember, this is an elderly, very small, kind of in terms of body weight, frail Japanese population, and that the comparator was placebo, not aspirin. If you look at the elderly analysis in Averroes, where they looked at standard dosing Apixaban versus aspirin as the comparator in patients over the age of 85, and if you recall, Averroes had similar design in that patients were only eligible for it if the physician was reluctant to put them on anticoagulation. They had equipoise about whether or not they would benefit from anticoagulation, so they were open to them being randomized to aspirin. The effect sizes for stroke prevention and the safety signal actually surpass what is seen in this new Edoxaban data. So for me, I think they would have done even better had they actually tested standard dosing in that trial. And there's some indirect comparisons with the elderly Averroes data that would support that. Now, if someone has already had a bleed, I think we're in no man's land because we don't have any, these people were excluded from these trials. So we don't know. I still favor standard dosing. Again, I want to maximize that robust 70% risk reduction in ischemic stroke to offset the risk of bleeding. And if I compromise efficacy, I'm worried that I have a losing bet. And that's my practice, but that's a more open question.
Okay, so another question on in your trial, the Edoxaban trial, when do you restart it after an ICH?
It's a good question. There's a lot of variability in practice, and the data would suggest anywhere between 3 days and 30 weeks. So that's how variable the data is. A lot of guidelines are suggesting somewhere between 4 to 8 weeks. The Canadian guidelines, ICH guidelines that we publish say wait at least 2 weeks. And in our trial, we say no sooner than 2 weeks. So after 2 weeks, anytime at the discretion of local investigator, and there's no upper limit to when the ICH could have occurred. So if you do have patients in your practice that had their ICH even a couple of years ago, they would still be eligible if you had ongoing equipoise about what was the best treatment regimen for them.
Are there any imaging markers that could guide you into that when you restart this in more of an acute
Imaging
setting?
markers, as it's a good question. So I think the first piece to answer is that I always repeat imaging to ensure that the hematoma is stable and isn't growing or there isn't any surprises. Where that often becomes an issue is in subdural bleeds. So I don't actually restart subdurals until about 8 weeks post bleed, because often when I've tried to image them sooner, I find new pockets of subacute bleeding, and some of the data would suggest that natural history. So I wait longer, about 8 weeks for subdurals. For intraparenchymal bleeds, lobar bleeds, I may wait more for about 4 weeks. And ultimately, for all bleeds, I'm looking for that hematoma to not only have stabilized in terms of growth, but to see that the density is resolving a bit. And that sometimes you can be tricked because the hematoma can expand perhaps, but due to clot retraction, the overall size may not change even though there was ongoing bleeding. So I'm really looking to see that that hematoma is becoming a bit less dense, a bit more translucent, before I restart anticoagulation. But this is, again, very speculative, just my own kind of opinion rather than guided by evidence.
Okay, last question, because it's already 9 and I got to go to clinic, but an average with understandable wide variability, how much patient-related disutility would you apply to a given microbleed, or is it mainly manifest as amplified risk of ICH?
In terms of an exact number, it's hard for me to answer that, but I would say that it is independent of ICH. So the accumulative burden of these microvascular injury, not only microbleeds, but white matter disease, lacunar strokes, covert infarcts, that contributes to age-related cognitive decline, age-related imbalances, poor balance and kind of the dysfunction in gait. So there is a functional impact of these lesions. At least they predict a decline in functional and cognitive decline with age and over time. What is uncertain is that whether they're independently contributing to it, or is it that they're just marking the underlying pathology that's contributing to this in some other fashion, and that we don't know. But it is independent of future symptomatic stroke-like events, because their accumulation of these lesions does contribute to cognitive and functional decline.
Okay, Ashkan, that was great review. Thank you very much for joining us today, and hope to see you soon, man.
Yeah, likewise. Thank you so much again.
Take care.
Bye-bye.